Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we are going to do one of the very useful topic, that is we call hypoxia. If you understand this particular chapter very nicely, you will understand dyspnea, you will understand cyanosis very clearly. And very frequently you will come across this particular group of people in your everyday practice. So we'll be discussing that topic. Now all my video lectures are mainly for educative purpose. They will be very useful to you in your exams, theory as well as oral exams. This particular lecture will be very useful to you in your theory exam. And to understand dyspnea, cyanosis, respiratory complaints and cardiovascular complaint, hypoxia is very useful to understand first, and then you will understand the pathophysiology of dyspnea, pathophysiology of cyanosis, etc. So basically hypoxia means, hypo means less, oxia means oxygen. When oxygen delivery to peripheral tissue is reduced, we call that as hypoxia. As routine, we will be discussing under all this heading: definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment and complications. Hypoxia basically is a clinical condition. So hypoxia means inadequate oxygen supply to body tissue, or we call it peripheral tissue. It can be to entire body, then we call generalized hypoxia, or it can be to one portion of the body, we call localized hypoxia. And localized hypoxia is very frequently because of the lack of arterial blood supply, and that is quite common, we call stagnant hypoxia. While hypoxemic hypoxia, respiratory and cardiovascular conditions are going to have central hypoxia, or we call it the entire body hypoxia or generalized hypoxia. So whenever there is a deficiency in delivery or utilization of oxygen at the tissue level, leading to, because of lack of oxygen supply, it will lead to change in functions, metabolism, and change in the structure of the cell or a tissue in the body. So hypoxia is a lack of oxygen supply at the tissue level, and anoxia means complete absence of oxygen supply to the tissue. A means total absence, hypo means diminished or low. So diminished supply of oxygen, hypoxia. Total absence of supply, AN, is absence. So complete absence of oxygen supply to the tissue is labeled as anoxia. Now there is one word we call hypoxemia. This too we have already defined. Emia means in the blood. When there is a lack of oxygen supply in the blood, we call hypoxemia. And when that hypoxemia lead to hypoxia, we call hypoxemic hypoxia. And this is because of decreased amount of oxygenation of hemoglobin. That's why it is labeled as hypoxemic hypoxia, because hemoglobin which is present in RBC will combine with oxygen and will become oxyhemoglobin, and oxygen will be now delivered to the peripheral tissue. And when that oxygenation of hemoglobin is lack or diminished, there is a lack in the oxygenation, or there is a diminished oxygen content in RBC, we call hypoxemic hypoxia. And when there is a lack of oxygen utilization by tissue, we call dysoxia, or we use the word histotoxic hypoxia. We don't go into detail regarding this. In a normal person, PaO2 is around 97%. Acceptable range has to be more than 80. If you want to classify into mild, moderate and severe, if it falls to 60, we call mild. If it is below 50, we call moderate. And if it falls below 40, we call that as a severe. So whenever there is a severe hypoxia, it will lead to a damage to the cell, and cell will undergo massive damage. We call hypoxemic damage. We'll be dealing in further slides. Basically, oxygenation of the blood, that is hemoglobin, will take place in respiratory system, and whenever lung fails to oxygenate, the oxygen content in the blood will reduce, and we call that as hypoxemic hypoxia. And this is called type 1 respiratory failure, where PaO2 becomes less than 60. Then we call hypoxemic hypoxia. Invariably, along with hypoxemic, there is hypercarbia, or we call hypercapnia, means excess of carbon dioxide. But in some of the condition, you can have a more hypoxemia, and your carbon dioxide level may be normal. The upper limit of the carbon dioxide level is 45. So if PCO2 becomes more than 45, we call that as a hypercarbia, or we call hypercapnia. And when there is a over level or increased level of CO2 in blood, it becomes more than 45, then we call hypercapnic or hypercarbic respiratory failure, and that is more in favor of type 2 variety of respiratory failure. So whenever you get an excess of carbon dioxide in a body fluid, that is in the blood, it is labeled as hypercarbia or hypercapnia. So whenever you come across hypercapnia with hypoxia, it is only when the hypoxia is caused by hypoventilation or circulatory deficiency, then you get a combination of hypercapnia with hypoxia. So that will be a classical condition where you will get type 2 respiratory failure. And whenever deoxyhemoglobin, means the hemoglobin which is not being oxidized or which is not oxygenated, hemoglobin does not combine with oxygen, it remains as a reduced hemoglobin, or we call it a deoxyhemoglobin. And if that percentage is more than 5 gram percentage in an arterial circulation, it will give rise to bluish discoloration of skin and mucous membrane, and that we call as cyanosis. We'll be discussing absolutely separate chapter on cyanosis, but at present we have given you a rough idea, that is bluish discoloration of skin and mucous membrane due to increased quantity of a reduced hemoglobin, means deoxyhemoglobin, and that has to be more than 5 gram percentage, and this has to be in a systemic circulation, means on an arterial circulation. So when that blood circulates in a capillary, it will give rise to bluish discoloration, and that will have bluish discoloration to the lips, nail beds, ear lobules, malar eminence, tongue, pharynx, soft palate, etc. This we call as a central cyanosis. We are not going to discuss regarding different types of cyanosis like central cyanosis, peripheral cyanosis, etc. in relation to the oxygen level. So whenever the oxygen level falls, there is less amount of hemoglobin which is converted into oxyhemoglobin. Hence, if there is more than 5 gram of oxygen which is not converted into oxyhemoglobin, it remains as a deoxyhemoglobin. We call it a reduced hemoglobin or deoxyhemoglobin, and if it is more than 5 gram, It appears blue in color, and it has to be on an arterial circulation, or we call systemic circulation, and then it will give rise to a bluish discoloration. So that is what we call as hypoxia producing cyanosis. There is one more word we call as asphyxia. It is different from anoxia. Asphyxia means simultaneously there is an acute hypoxia and it will result into accumulation of carbon dioxide, we call as hypercapnia. And this asphyxia will be very frequently because of an acute airway obstruction, either because of foreign body or because of secretion collecting in the larynx and trachea, or aspiration, drowning, etc. So aspiration of meconium, fecal matter, fluid, blood, food, vomiters, foreign body, etc. So they will produce aspiration occlusion. The person will aspirate this material, any one of this material, and then it will occlude the lumen, and that we call as acute airway obstruction. Or larynx goes into spasm in reaction to foreign body, or because of aspiration, or during seizures, or because of tetanus, or in case of tetany. Then also the air will find difficulty to enter into trachea. Or there may be edema of larynx, like infection, the most common infection, croup, diphtheria, laryngitis, maybe viral, maybe bacterial, very rare to have tubercular. Then inflammation may be secondary due to chemical fumes or chemical aspiration. Laryngeal edema can also occur in case of anaphylaxis, angioneurotic edema, etc. Or person can be strangulated by external compression or smoothering, or drowning, which can be dry or which can be wet. If person is aspirated fluid during drowning, it will become wet, and if person is not aspirated, it will be dry. Usually, if the person has been thrown in water after death, it will be dry, but before, it will be by and large wet. So this will be all the condition which can produce obstruction of the airway, and because of obstruction of the airway, oxygen supply to the lungs will be markedly reduced. Hence there will be an acute severe hypoxia. Plus there will be accumulation of carbon dioxide, because carbon dioxide cannot be thrown out. So we will have an accumulation of carbon dioxide, and that will give rise to hypoxemic, hypercapnic respiratory failure. And this will be type 2 variety of respiratory failure. There is one more variety of a hemoglobin, where hemoglobin is converted into what we call as a methemoglobin, and that is very frequently converted by nitrites, nitrobenzene, which will convert ferrous form into ferric form by action of oxidization, that is done by nitrite or by nitrobenzene, and now you get a formation of a methemoglobin. Now this methemoglobin has got a very poor ability to carry oxygen, hence person will have a lack of oxygen supply, and that will produce hypoxia. So do remember this, when ferrous, that is iron form in hemoglobin, is converted into ferric form, it will give rise to formation of what we call as a methemoglobin, and when methemoglobin is present in blood, we call as a methemoglobinemia, and that has got a very poor affinity to carry oxygen, hence it will produce hypoxia. Same way, sulfhemoglobin, which is containing a sulfur part of it, so pickle vegetables which are containing nitrates. So nitrate will react with Fe, will convert that into Fe3, that is ferric form, and that will be giving rise to formation of a sulfhemoglobin, and that has again got a poor affinity, and very frequently this will be done by what we call as a sulfur containing compounds, and these two compounds, that is methemoglobin and sulfhemoglobin. In methemoglobin, good number of times there is a strong genetic predisposition. In sulfhemoglobin, usually it is secondary due to drugs. So these are called androgynous cyanosis. Androgynous cyanosis. We'll be discussing again in a chapter of cyanosis. There is one more variety of a hypoxia we call as a hypermetabolic hypoxia, where there is increased metabolism, there is increased demand, oxygen supply is adequate but the demand is more. So relatively the person will develop an hypoxia, and this variety is described as a hypermetabolic hypoxia. Some of the classical example like thyrotoxicosis, anxiety, those group of disorders. Now there is one more word which has been recently added in the era of this COVID-19, that is called silent hypoxia or happy hypoxia. Understand this very well. Whenever there is an hypoxia, along with that there is accumulation of carbon dioxide, and this carbon dioxide is a powerful stimulant for respiratory response, which is a compensatory mechanism for increasing the ventilation. Now in case of a COVID infection, this phenomena does not take place because of desensitization, as well as there are other mechanisms we will not be discussing at present. So that will produce, person will have a hypoxia, but there will be no increase in respiratory rate, there will be no increase in ventilation, hence person will not complain of shortness of breath, a person will not have tachypnea, still person is hypoxic, and that's why it is labeled as silent hypoxia or happy hypoxia. So it is, we don't feel breathlessness even if we don't get much amount of oxygen as we require. We feel breathless when we are unable to expel carbon dioxide. So whenever the carbon dioxide is accumulated in body, that stimulates the respiratory center, producing hyperventilation, or we call increased ventilation, so that you provide more oxygen to the body, and this is absent or this is not appearing in a patient with a COVID infection. Hence person do not have any symptom signs of hyperventilation in the form of tachypnea or dyspnea, and that person is described as a silent hypoxia or happy hypoxia. Just remember this. This is one new terminology, so you will have to understand that, and someone can ask you in your oral. There are 4 classical groups of hypoxia. Now we'll be adding 5th and 6th, we'll be adding at the end, but as far as oral exam is concerned, these are 5 classical. The common name which is utilized in everyday practice is hypoxic hypoxia, or it is also called as a hypoxemic hypoxia, or third term instead of hypoxic, hypotonic hypoxia. Second group, if you understand the pathophysiology, in this particular group the hemoglobin is not converted into oxyhemoglobin, hence the oxygen content in the blood is less, and that's why it is labeled as hypoxemic or hypoxic. But if there is a lack of hemoglobin in blood, and because of lack of hemoglobin, the total amount of hemoglobin converted into oxy is full, but the amount of oxygen, because of lack of hemoglobin, so the content of oxyhemoglobin in blood is less, hence oxygen supply is less, and this is now labeled as anemic hypoxia, or it is also called as isotonic hypoxia, hematogenous hypoxia, hypemic hypoxia, or also described as anemia with dyshemoglobinemia, where you can also include what we call as two groups, that is methemoglobin, sulfhemoglobin. Also some people includes carboxyhemoglobin. Stagnant hypoxia means there is a full oxygen content in the blood, there is adequate quantity of oxyhemoglobin, but the blood flow or the blood supply to the organ is diminished. When it is diminished to one specific organ, it is called localized or ischemic, or we call distributing. But if it is diminished to entire body, as for example in case of a severe congestive heart failure, severe shock stage, then it is also labeled as a stagnant hypoxia, hypokinetic hypoxia, or circulatory hypoxia. These are the common words utilized for that, and that is because of failure of circulation or failure of blood supply. While when oxygen content is adequate, supply is adequate, hemoglobin content is adequate, oxygenation of hemoglobin is adequate, still a cell cannot utilize that oxygen. It is called histotoxic hypoxia, or it is called oxidative hypoxia, or histogenous hypoxia, and classical example of that is cyanide poisoning. I already mentioned regarding hypermetabolic, not very common, but whenever there is an increased metabolism, oxygen supply is adequate, but demand is more. Now, if the oxygen supply does not meet the demand, there will be lack of oxygen. That will produce hypermetabolic hypoxia. Also, we have mentioned silent or happy hypoxia, which is a term which has been mentioned in the era of COVID-19. I've already explained before. Now, if we look at the comparison of hemoglobin, arterial oxygen, and rate of blood flow, in hypoxic, arterial PO2 is diminished, hemoglobin is normal, blood flow is normal. In anemic, hemoglobin is low, while oxygenation is adequate, blood flow is adequate. In stagnant, blood flow is poor, while arterial oxygenation is adequate, hemoglobin content is adequate. In histotoxic, all the three are normal, what we have mentioned. So if you understand this, this explains you the entire pathophysiology. So do remember, 4 classical variety. In hypoxic, the oxygenation is poor. In anemic, hemoglobin is low, hence there is decreased quantity of oxyhemoglobin in blood. In stagnant variety, poor circulation or poor blood flow reduces the oxygen supply. And in histotoxic, poor utilization. So this 3 is a supply, this is utilization. So do remember that. Indirectly, it makes you what will be the pathophysiology. Here something else is added. Cyanosis will be very classical in case of hypoxic hypoxia. It will be less likely in case of anemic hypoxia, or nearly we call as an absent. In stagnant hypoxia may be present, but it will be present if there is a central causes, then it will produce central cyanosis. And if there is a diminished blood flow in one area, so cyanosis will be present in only one area of a body, or the portion where the blood supply has been diminished. While in histotoxic, very rarely you will get cyanosis, or usually we say cyanosis will be absent in case of histotoxic. So if you look at the cyanosis, It is classically in case of hypoxic and also present in case of a stagnant hypoxia, particularly in case of a central variety, and in a local area we call local cyanosis or peripheral cyanosis, or we call localized cyanosis in patient who has got diminished blood supply because of the occlusion of the arterial blood supply. We have already mentioned this: hypoxic, anemic, stagnant and histotoxic. Classical example of histotoxic is cyanide poisoning. Hypoxic is mainly because of we call environmental or high altitude, respiratory condition and cardiovascular conditions. Anemic hypoxia is mainly because of decreased hemoglobin content, that is anemia, or because of abnormal hemoglobin, particularly methemoglobin and sulfhemoglobin, and you can also include carbon monoxide poisoning. And in case of a stagnant hypoxia, classical example of generalized will be circulatory failure, particularly congestive heart failure, and localized will be because of occlusion of a artery. So that will be the conditions. If we go through the etiology, we have already mentioned some of those. So lung will produce hypoxic hypoxia, cardiovascular system right to left shunt, congestive heart failure will also produce hypoxic hypoxia. High altitude drowning will also result into hypoxic, or even we call as a any condition which produces aspiration will also produce hypoxic variety, and even strangulation will also end up with hypoxic variety. As far as the blood pathology is concerned, if hemoglobin is low, it will produce hypemic, or we call as a anemic hypoxia, because of reduced number of RBC and reduced number of hemoglobin. That is, if RBC is reduced, hemoglobin is reduced and hematocrit is reduced, it will end up with anemia. So that will produce hypemic, or we call anemic or hematogenous. Carbon monoxide poisoning, sulfhemoglobin, methemoglobin, and also in case of a congenital hemolytic anemias where hemoglobin is usually low, like thalassemia. In case of circulatory, distributive or stagnant hypoxia, it is mainly because of diminished perfusion. Classical example is congestive heart failure, where heart is not able to eject adequate quantity of blood into periphery, and adequate quantity of the blood also does not reach to the lung. Hence, less amount of blood will get oxygenated, and it will produce diminished oxygenation of blood, will result into hypoxia, and that will be again central hypoxia. Classical example of that is acute pulmonary edema in case of a left ventricular failure or congestive heart failure, and that will lead into central hypoxia and central cyanosis. At the level of tissue, we call it a tissue hypoxia or histotoxic hypoxia or histogenous hypoxia, and this will be because of poor utilization of oxygen at the mitochondria because of damage to the mitochondria, as for example in case of a cyanide poisoning, particularly cyanide poisoning. Also in case of a dinitrophenol, rare, but cyanide is the most common. They say that also in case of a carbon monoxide poisoning, also it can produce what we call as a histotoxic hypoxia. So in case of hypoxemic, high altitude respiratory condition, when person is breathing a mixed gas like more of carbon dioxide and less of oxygen, it is containing low PO2, all those conditions, and good majority of the condition we have already mentioned. As far as respiratory condition, common example bronchial asthma, COPD, sleep apnea, pneumothorax, poliomyelitis, brain tumors, which produces diminished ventilation, that can also produce hypoxia, and this will produce more of what we call as a hypercapnic hypoxia, leading to type 2 respiratory failure, emphysema, fibrosis, pneumonia, bronchiectasis, bronchiolar obstruction, etc. This will produce poor oxygenation. This will produce type 1, that is hypoxemic variety, as compared to hypercapnic variety, that will be type 1 respiratory failure. Congestive heart failure or low cardiac output will produce more amount of stagnant hypoxia, and also because of diminished output to the lung, less amount of blood will enter into the lung, and as the less amount of blood will enter into the lung, it will have a diminished oxygenation, and because of less hemoglobin get converted into oxyhemoglobin, it will produce diminished oxyhemoglobin in blood, and that will produce central hypoxia and central cyanosis. Very classical, it will take place in a case of a acute left ventricular failure resulting into pulmonary edema. Simultaneously, because of decreased cardiac output from LV, there is a stagnant hypoxia because of poor blood flow, and that will produce peripheral cyanosis and peripheral hypoxia, and that is together we call as a mixed cyanosis. So person who has developed an acute congestive heart failure or severe congestive heart failure, there are multiple causes of this. We are not going into detail at present. In theory, you will have to write down all those examples like acute myocardial infarction, acute MR, acute AR, then in case of a cardiomyopathy, then acute cardiac tamponade, ventricular aneurysm rupture, etc. There are many conditions. Cardiac arrhythmias, ventricular arrhythmias, all those conditions. We are not going into detail at present. And in that condition, you will have both central as well as stagnant hypoxia because of reduced blood supply to the periphery. So that will be what we call as a cardiac etiology. Also, it will produce element of hypoxemic hypoxia. In case of anemia, because of decreased hemoglobin, as such there is a diminished hemoglobin level in blood. Even if that entire hemoglobin gets oxygenated, say person has got hemoglobin of 7 gram. If even all 7 gram gets oxygenated, you will have only supply of oxygen because there is a 7 gram of oxyhemoglobin in blood. Hence this is a diminished blood supply or a diminished oxygen supply, and that will produce hypoxia, and that we label as anemic hypoxia. Also, you will get hypoxia because of carbon monoxide poisoning, because of sudden decrease in the hemoglobin in case of an acute hemolysis or massive hemorrhage, which will finally end up with anemia. Also because of sulfa, which will produce sulfhemoglobin, or because of a congenital defect, and because of oxidation of ferric form into ferrous form will give rise to methemoglobin formation. In both these conditions, they have got a poor affinity to combine with oxygen, and that will result into poor supply of oxygen. We call as anemic hypoxia. So decreased hemoglobin, altered hemoglobin like sulfhemoglobin, methemoglobin, and also in case of a carboxyhemoglobin, that is because of carbon monoxide. We already mentioned some of the causes where you will have a diminished blood supply like congestive heart failure, hemorrhagic strokes, vasospasm, thrombosis, embolism. This vasospasm, thrombosis, embolism, and surgical strokes, all this condition will be secondary due to occlusion of the artery, leading to local diminished blood supply, and that will give rise to localized hypoxia, and that will be associated with localized cyanosis. And if there is a complete occlusion because of thrombosis, embolism, or because of severe vasospasm, the person will end up with even gangrene. And when it is an arterial gangrene, it is usually we call as a dry gangrene, and there will be line of demarcation and shrinkage of the part what is being affected, and that we label as a stagnant hypoxia. Methemoglobin I have already mentioned. Among acquired condition, nitrates, aniline compounds, oxidizers, particularly potassium permanganate, pyridine groups of compounds, methylene blue, and some of the another compound like barbiturates, aspirin, pilocarpine, maybe. As far as primary is concerned, very frequently it is because of a genetic defect in a gene, and that can give rise to methemoglobinemia. While a cyanide poisoning will give rise to histotoxic variety of hypoxia, because it will produce inhibition of oxidative phosphorylation in a mitochondria, and even in presence of oxygen, oxygen cannot be utilized because you cannot have राधे राधे नहीं तो or there can be mitochondrial injury, like in a case of a septic shock. Once in a while you can come across in that condition. We call bacterial toxins. Occasionally in radiation therapy. Very rare to get in a case of a severe vitamin deficiency like B1, B2, etc. because they forms an coenzyme in oxidative cycle. So this will be histotoxic variety. Don't forget regarding carbon monoxide poisoning and also sulfhemoglobinemia in those two variety also. This is a slide just out of way. These are all the different etiology which are being for hypoxic, anemic, ischemic variety and histotoxic variety. Even diphtheria is known to produce damage to the mitochondria and can produce histotoxic variety because there are toxins which are liberated from diphtheria, which are diphtheritic toxin. They can produce damage to mitochondria. So do remember this. This is almost we have done a pathophysiology. I'll go to this slide. This is more simplified. From atmosphere, you get an oxygen. It will go to the lung, and in lung, at the level of alveoli, it will oxygenate the hemoglobin, and that oxygenated hemoglobin will be transported by help of a heart to peripheral tissue, and peripheral tissue will utilize that to what we call as burn glucose in mitochondria to produce ATP, we call as energy. So if there is any pathophysiology in the atmosphere or in the lung, that will produce hypoxemic or hypotonic variety of hypoxia. If the carrying of the oxygen becomes defective, lung is normal, atmospheric oxygen is normal, but hemoglobin, the total content of hemoglobin or the type of hemoglobin is abnormal, it will produce what we call as a anemic variety of hypoxia, anemic variety of hypoxia, and that can be because of severe anemia, sulfhemoglobin, methemoglobin or carboxyhemoglobin. Now if all these three are normal, atmospheric oxygen is normal, lung is normal, so oxygenation in lung takes place is normal, hemoglobin content is normal, but now circulation is affected. So if anything which happens at the level of cardiovascular system, it will produce a stagnant variety of hypoxia. Even if the heart is normal, say first mechanism, that is ventilation, diffusion, transport is also normal, but now utilization cannot be there by a peripheral tissue, we call as a histotoxic variety of hypoxia. So very simple to understand. So you can classify into defect in oxygen supply, we call external respiration, that is hypotonic or hypoxic variety, hemic variety or hematogenous variety, circulatory or stagnant variety. These are three because of defective oxygen supply and defective utilization, that is internal respiration, and that is called as a histotoxic or histogenous or disoxidative variety of hypoxia. So hypoxemic, decrease oxygen in the blood. Hypoxic means decreased oxygen supply to the tissue, may be generalized or may be local or we call regional. Regional is always because of ischemia, that is because of some arterial pathophysiology where there is an occlusion of the artery giving rise to regional. Classical example MI, mesenteric ischemia, peripheral arterial disease, etc. While generalized classical example congestive heart failure. And even after that supply, if it cannot be utilized, classical example of histotoxic we call as a cyanide poison. Same thing explained here. If anything which produces oxygen supply in the atmosphere like high altitude or drowning or asphyxia, that will give rise to hypoxemic variety. Any pathophysiology in the lung, maybe at the level of alveoli or maybe at the level of the entry of oxygen, will produce hypoxemic variety. Once the hemoglobin gets oxygenated, it can be easily pumped out by the lung, from the lung into LA, and from LA into LV and to the systemic circulation, and that will be a cardiac conditions. So anything which produces a diminished cardiac output will give rise to what we call as stagnant variety of hypoxia. But any condition where there is an abnormal quantity or variety of hemoglobin, that we'll call as anemic hypoxia or hematogenous hypoxia, either because of a low hemoglobin or because of an abnormal hemoglobin. And if it is this hemoglobin content is normal, oxygen content is normal, but it is not utilized by peripheral tissue, then we call that as a peripheral or we call as histotoxic hypoxia. It is not utilized by a cell or a tissue because of damage to the mitochondria. Now, because of hypoxia, there is accumulation of carbon dioxide more as compared to oxygen. This carbon dioxide combines with water to form carbonic acid H2CO3, which is broken down into H and carbon dioxide bicarbonate, and that H ion is a powerful stimulant to the respiratory center, as well as carbon dioxide is also a stimulant. Or if the body temperature gets elevated, that is also a stimulant to the respiratory center, and that respiratory center will stimulate autonomic nervous system center or we call vasomotor center, which is present in hypothalamus, and that will give rise to what we call as a hyperventilation. And in hyperventilation you will have an increase in the rate as well as depth of respiration, that is tachypnea with depth, and that will try to increase the oxygenation. And this is what is going to happen as a preliminary response to any condition which produces whether hypoxemic or we use a word what we call as anemic, stagnant or histotoxic variety of hypoxia. The person, not because of lack of oxygen but because of excess of carbon dioxide or because of acidosis or because of increased body temperature, there will be tachypnea and hyperapnea, and that will try to compensate by increasing the respiration and increasing the ventilation. So this is the first thing what is going to happen. So this is the entire mechanism we have explained once, twice, thrice. So this is hypoxic, this is hypemic or we call is anemic. This will be stagnant. Cardiovascular causes will give rise to stagnant. At the peripheral tissue, histotoxic, 4 classical variety. And when there is an increased demand, the supply is normal, demand becomes more, it will be hypermetabolic. And if this cannot happen, hyperventilation doesn't take place, and person is having hypoxia, carbon dioxide level is normal, secondary due to COVID-19 infection, then it is called as a happy hypoxia, or we call as silent hypoxia. In respiratory system, it can be ventilatory coefficient defect, or because of shunt, or because of obstruction, or because of damage to the alveoli, or because of damage to the ventilatory mechanism, hypoventilation. And whenever there is an hypoventilation, it will give rise to accumulation, excess of accumulation of carbon dioxide, giving rise to hypercapnic or hypercarbic variety of a respiratory failure. We call it a type 2 respiratory failure. Same thing what we have explained is mentioned in a different way. At your leisure time, you can go through whatever we have shown you here and this previous diagram. We explained that all this, it is same, but explanation is in a different types of diagrams. This is one type of diagram, this is another variety of diagram, how exactly the respiratory center is being stimulated and you become breathless. That entire mechanism is being explained, that your carotid body, central chemoreceptors, cortical centers, limbic system, etc. will be stimulated by because of presence of carbon dioxide, excess of carbon dioxide we call hypercapnia, or because of acidosis, or because of altered VQ, which will give rise to excess of PCO2, and that will also stimulate the carotid body. And all this mechanism, and this can happen in a case of an airway obstruction, increased mechanical load, pulmonary fibrosis, interstitial disease, then deflation or decrease in the lung volume like pneumothorax, collapse or effusion. All this mechanism will give rise to hypoxia with hypercapnia, and that diminished oxygen concentration does not stimulate much, but it is PCO2 is more stimulant to these chemoreceptors as compared to oxygen lack. So pH and chemoreceptors in central, that is in the brainstem and in a carotid body, will be stimulated, as well as there is a cortical drive, there is a limbic system drive, that is because of emotions, and all those will stimulate the respiratory center, and that will produce tachypnea and hyperapnea. This is same thing explained what we have explained in previous at your leisure time. This is another way to explain. This is again abnormal regulation of breathing, obstructive disease, respiratory disease. This is at the level of respiratory disease. This is abnormal oxygen, that is stagnant hypoxia. This is hypoxemic hypoxia, and all those will stimulate the respiratory center and will give rise to increase in respiration. So in hypoxemic, high altitude, diffusion problems, hypoventilation, shunting, and ventilatory coefficient mismatch, all this mechanism will produce hypoxemic hypoxia, and this is the most common variety of hypoxia. Tissue hypoxia we have already mentioned, that will be inadequate oxygen supply, or there may be complete anoxia. If there is no oxygen supply, there will be anaerobic glycolysis, excessive lactic acid production, you will have a high anion gap metabolic acidosis, no ATP production, no energy, and because of there is no oxyhemoglobin, there is excess of deoxyhemoglobin, which will produce central cyanosis. To compensate that, tachycardia and tachypnea because of stimulation of cardiac center as well as respiratory center, and because of lack of oxygen supply, lack of energy, no ATP, person will be lethargic, confusion, And if it is in excess, severe hypoxia, that will produce cerebral damage, cerebral edema, we call hypoxic encephalopathy. So you will have a cerebral edema, raised intracranial pressure, herniation, and that can end up with coma and seizures also. And if it is very severe enough, not treated early, even person can succumb, that is death. So finally, this tissue hypoxia is because of ischemia or hypoxemia, or maybe because of hemoglobin defects or abnormal hemoglobins, or maybe at the level of tissue because of histotoxic hypoxia, any variety of that. And that will give rise to, we already mentioned that it will give rise to anaerobic glycolysis, which will have production of only 2 molecules of ATP, lactic acid, because of high anion gap metabolic acidosis, it will damage the protein part and it will damage the cell. Because of lack of ATP, also there is a damage to the cell because there is no energy supply, and that will give rise to what we call as a damage to the sodium potassium pump. And because now sodium potassium pump is damaged, sodium can easily enter into now cell, and along with sodium water will enter. You will get edema, and that is one of the reasons why in case of a hypoxic encephalopathy there is accumulation of sodium and water giving rise to cerebral edema, raised intracranial pressure, herniation, altered level of consciousness, seizures, and may end up with coma and death. That is very, very classical. At the same time, because of lack of ATP and because of acidosis, there is even damage to what we call the calcium channel, and calcium is required to activate the different enzymes. Now because the calcium now start entering inside into the cell, it will produce activation of protease enzyme which will break down the protein, and that will damage the cell wall. It will also activate endonuclease enzyme which will break down the DNA. It will also hydrolyze the hydrolytic enzymes, and that will also break down the protein content of the cell. Indirectly, this sodium potassium pump damage and calcium channel activation will damage the cell and will give rise to irreversible cell damage. If there is an oxidative cycle, then it will produce 36 molecules of ATP. So this will provide energy, and it will activate sodium potassium pump, as well as it will deactivate the calcium entry into the cell, and thus reducing the activation of the enzyme which will produce self-destruction. So it will just produce 2 molecules of ATP in absence of oxygen. That is called anaerobic glycolysis. I have already explained silent hypoxia, that in presence of COVID infections, the lungs do not become stiff and they are not heavy with fluid, hence remains compliant. So they are able to expel out the carbon dioxide. Hence carbon dioxide cannot build up in lung, cannot build up in body, and this will not stimulate your respiratory center to produce hyperventilation. Hence person is not hyperventilating. Person is hypoxic but not hyperventilating, and that's why it is labeled as silent hypoxia, or we call happy hypoxia. Do remember that word. So this is the entire mechanism. There is a change in the body color. There is also what we call as insensitivity or desensitization of this center. There is subnormal carbon dioxide. There is a suboptimal ventilation. Person will be cyanosed, but still there will be no hyperventilation. So no dyspnea, no anxiety, no confusion, and person is happy. That's why it is labeled as happy or silent hypoxia. Person will have a severe oxygen lack. There will be preserved central blood flow. Drive is reduced. Brain PeCO2 is also reduced. Hence, there is decreased hyperventilation. So there is a depressed central stimulation as well as the peripheral stimulation because of COVID, and that will not stimulate the respiratory center. Hence, person will not have dyspnea, no anxiety, no confusion, and that's the reason why the person is happy. He is hypoxic, but he doesn't feel, and that's why it is called as a happy hypoxia or silent hypoxia. This can be asked because this is a recent thing which is going on at present. Do remember. What are the other effects of hypoxia? Hypoxic ischemic encephalopathy is the most dangerous one which happens. There will be hypoxic injury to the cell. Because of severe hypoxia, pulmonary artery will undergo spasm, and that will give rise to pulmonary hypertension. And secondary to pulmonary hypertension, now you will have increased resistance. Right ventricle will have to do excessive overload work, and person will have a high chance of going into congestive heart failure. As well as because of chronic hypoxia, there will be increased erythropoietin production. Erythropoietin will produce erythrocytosis by increased erythropoiesis in bone marrow. So RBC volume will increase, count will increase, and that will give rise to what we call as a hyperviscosity. Hematocrit will also increase, and this is because of a chronic hypoxia. This too will happen in a chronic hypoxia, not in acute hypoxia. Now, because of the central system being stimulated, that is stimulation of the carotid body, stimulation of the what we call as a brain, and stimulation of central receptors, there is increased breathing rate, or we call tachypnea. There will be vasoconstriction of the lung blood vessels, that is it will produce pulmonary hypertension, and there will be also stimulation of a cardiac center giving rise to tachycardia. You will have a peripheral vasodilatation, and that will increase the blood supply to the periphery and increases the blood supply to the peripheral tissue. These are all, there are some beneficial effects, some effects will produce damage to the organs. So anaerobic metabolism, lactic acid acidosis, protein catabolism, we already mentioned, we have shown you in the previous slides. Fat will have a ketoacidosis. So all those will have a dangerous effect on the different organs. In respiration, there will be stimulation of peripheral chemoreceptor and giving rise to what we call as a tachypnea. Cardiovascular system will be stimulated, giving rise to tachycardia and little elevation of blood pressure. As far as GI tract is concerned, person will have anoxia, nausea, vomiting. Because of a deoxyhemoglobin circulating in blood, you will have a central cyanosis, and in case of a local ischemia, you will have a peripheral cyanosis or localized cyanosis and even gangrene. On brain, because of a lack of blood supply, depressed mental activity, impaired judgment, anxiety, drowsiness, disorientation, headache, and later on person will get seizures, coma, and even person can die. And we have told you that because of cerebral edema, raised intracranial pressure, herniation, altered level of consciousness, seizures, coma, and then death. Because of increased work capacity, the person tries to do more and more work, but slowly that muscle gets fatigued, and now person will go into what we call as respiratory failure. Because of a chronic hypoxia, we already mentioned, you will start developing pulmonary hypertension, erythrocytosis, and secondary to erythrocytosis, hyperviscosity. Person will also have what we call as a secondary polycythemia, hyperuricemia, chances of gout also, etc. These are all the other odd effects. We already mentioned little bit regarding a peripheral cyanosis as well as central cyanosis, which will be more common with what we call as a ischemic variety. very rare to get in anemia and in case of a histotoxic variety. It is absolutely rare in these two varieties. But in hypoxic variety, there is always a central cyanosis, while in ischemic variety, it will be a central cyanosis. And in case of a classical ischemic, localized, there will be local area will have ischemic damage, which can be right from ischemia to necrosis, leading to myocardial infarction, mesenteric gangrene, peripheral gangrene, etc. Clinical features will depend upon how fast it develops and how severe the hypoxia is. In case of hypoxia, there is no signs of breathlessness. Hence, this is concerned because it is very, very dangerous. No doubt we label that as a happy, but it is very, very dangerous because person doesn't feel breathless. Hence, he will not approach to a doctor also. We have to pick up this group, and you can identify that by having pulse oximeter. Now, there are two common words which are being utilized. We divide hypoxia into two stages, early hypoxia and late hypoxia signs. In early hypoxia, we call as a RAT, that is restlessness, anxiety, tachycardia and tachypnea. While in a late signs, it is described as bradycardia, extreme restlessness, dyspnea, and this is severe dyspnea, and one more word is added, that is cyanosis. In pediatric groups, it is called FINES, feeding difficulty, inspiratory stridor, flaring, nasal flare, expiratory grunting sound, sternal retraction, etc. This will be commonly seen in a pediatric group. Not common to see in an adult. In adult, you can see that there may be inspiratory stridor, nasal flaring, intercostal retraction, sternal retraction will not be there, grunting will not be there, and feeding difficulty will not be there. But the person who is markedly having a respiratory distress will have what we call as a speech disturbances. He will find difficulty in communication because he will not be able to speak because he is markedly breathless. So there will be respiratory findings like tachypnea, dyspnea or shortness of breath, cyanosis. In cardiovascular system, palpitation, tachycardia, cardiac arrhythmia. Initially there will be little elevation of blood pressure, and later on person can develop hypotension and even fall of blood pressure. And secondary to severe hypoxia, person can also have an anginal pain, diaphoresis, secondary due to vasodilatation, and person may be even in a stage of a shock stage. As far as CNS is concerned, in early stages, headache, impaired judgment, we call as a cognitive function disorders, inappropriate behavior, confusion, euphoria, delirium, restless. In a late stages, because of cerebral edema, raised intracranial pressure, headache, altered level of consciousness, stupor, seizures, coma, and later on person can go into cardiorespiratory arrest and death. As far as the neuromuscular junction is concerned, weakness, tremors, we call carbon dioxide accumulation will produce asterexis or flaps. It is also called as a hypercarbic asterexis, very common in a chronic bronchitis, corpulmonal groups. There will be hyperreflexia in coordination, and you can have what we call as a high anion gap, metabolic acidosis secondary due to lactic acid acidosis, and you will have a abnormality in the sodium as well as water. So you will have a disturbances in sodium and electrolyte imbalance very frequently. As far as sodium and water is concerned, sodium will be shifted inside into the cell, leading to hyponatremia and edema like cerebral edema. Do remember this. Person will develop a respiratory failure which may end up with chain stroke followed by a Bird's breathing. If a person is exposed to a very high altitude, he can develop a pulmonary edema, secondary to high altitude we call as a HAPE, high altitude pulmonary edema, quite common. You will see this, you will see this whenever a person is suddenly exposed to a very high altitude. Do remember that. It is because of hypoxic pulmonary vasoconstriction leading to exudation of fluid, and that will give rise to acute high altitude pulmonary edema, and person can be in a bad shape. So we already mentioned tachypnea, dyspnea, respiratory distress sign like intercostal retraction, sternal retraction in a children, intercostal retraction, nasal flaring in adult as well as children, grunting sound in a children, diaphoresis, tachycardia, hypertension, very common in all. Because of severe hypoxia, confusion, agitation, restlessness, somnolence. Somnolence is because of the carbon dioxide excess, and secondary to carbon dioxide excess now you can have flaps, and then person will have hyperventilation, and later on person will go into type 2 variety of respiratory failure because of excess of deoxyhemoglobin more than 5 gram in a circulating blood, cyanosis. In case of hypoxemic hypoxia, respiratory and cardiovascular condition, central hypoxia, you will have a central cyanosis. In case of stagnant hypoxia, because of the ischemic variety, you will have a peripheral cyanosis, or localized hypoxia and localized cyanosis, localized gangrene. While in case of a histotoxic variety, there will be no cyanosis, and in case of anemic variety, there will be no cyanosis. As far as investigation is concerned, history is very, very important. Vital signs examination, physical and systemic examination is absolutely necessary. You can use pulse oximeter to find out the oxygen concentration on an arterial side, but best way is by ABG. If ABG is not available, you can go for a venous to find out the amount of acid-base imbalance, and also you can find out the electrolyte imbalance secondary due to hypoxic damage. Then to find out the type of hemoglobin, you can go for spectrophotometry to identify sulfhemoglobin, methemoglobin. You can do the hemoglobin concentration to find out the anemia. Also you can find out the carboxyhemoglobin. Then you can go for respiratory system examination by PFT, X-ray chest CT, HRCT, MRI, or by biopsy. And in cardiovascular system, finding out etiology for cardiovascular system, ECG, echo, and if required, angio, CT angio or MRI angio, or you can have a plain X-ray chest PA view. If you want to find out the what we call is the infective pathophysiology, particularly septic shock, blood culture, CBC, etc. And then depending upon any other pathophysiology you are suspecting, you can go for investigation depending upon suspected etiology. We already mentioned this. Chest X-ray is for respiratory system, ECG is for heart, ABG is to find out the acid-base balance and electrolyte imbalance, and other laboratory parameter to find out which system is being involved. So X-ray chest is absolutely, you can see here this is a pneumothorax. You can see also here there is a pneumothorax. This is partial pneumothorax. This is much more severe. You can see there is a fractured rib, and this is subcutaneous emphysema, or we call surgical emphysema, and mediastinum is grossly shifted to the opposite side. This is leading to what we call the tension pneumothorax, and this is the collapsed part of the lung, and this is pneumothorax with fractured ribs, and this because of multiple fracture this will be a flail chest, and you can see this is a surgical emphysema. This is pneumonia. This is again a pneumonia. This is bilateral haziness. Always try to rule out ARDS. As far as management is concerned, in case of hypoxia, treat the underlying cause is a main important part. Because a person is already having a lack of oxygen, so supplementation of oxygen will depend upon what is the disease, maybe non-invasive or invasive, etc. Full flow we call at a high level or low level. depending upon the severity and type of hypoxia. Position of the body is very important. Say in ARDS, prone position is very useful. Also in case of a COVID, also prone position is very helpful. But say person with a cervical neck fracture, cervical vertebral fracture, you have to first stabilize the cervical spine. In that case, even intubation becomes very difficult. You might require a tracheostomy. Always keep airway patent, breathing good, breathing good. In case of a bronchoconstriction, bronchodilation. In case of congestive heart failure, diuresis. Reduce oxygen requirement by other mechanisms, and consider BT, we call PEXL, in case of a severe anemia. All this may be there. This is everything is given in a one simple things: how you assess, how you approach to a person with a severe hypoxia, etc. At your leisure time you can go through. Step 1 is always assess the airway. Step 2, X-ray chest. If there is anything in that, you can go for intubation and oxygenation. That is, if person is hemodynamically stable, then you may not require to intubate. But if the person is hemodynamically unstable, you might require to intubate and oxygenate the person. And then you can check for X-ray, ABG, and you can go for what we call as a even tracheostomy, and you can go for even ACLS protocols. And if there is no pulse, you will have to go for what we call as a ACLS and advanced cardiac life support will be absolutely necessary. You will require a ABG with electrolyte levels and treat that also. And if the person has got severe CNS, then you might require even to hospitalize in an ICU and put him into ICU and treat depending upon the basic etiology and severity of the hypoxia. These are all those things what we have mentioned. I'm not going into detail. That is, you might require a ventilation. You look at the lungs, chest X-ray, suction catheter to maintain the airway patent, bronchodilators, etc. So airway, breathing and circulation is absolutely necessary. Now we say that circulation, airway and breathing. So first always try to have a circulation first and airway, then breathing. Oxygen therapy is absolutely necessary. So main goal, treat hypoxia, decrease workload and decrease myocardial workload. And while giving that, you make the patient comfortable and maintain the level of oxygen what is being required, and you try to reduce the damage because of hypoxia. So benefit of oxygen therapy is helpful in some type of hypoxia, mainly in hypoxic variety, cyanide poisoning, carbon monoxide poisoning, gas gangrene, but it is not useful in anemic and ischemic variety, particularly stagnant variety, in which you will require to treat the basic condition. Here in case of anemic variety, you will require to give a PEX cell, and in case of a stagnant variety, you will require to treat the congestive heart failure and treat the occlusion of the artery. In methemoglobin, you will require an oxygenation where it will be helpful, but simultaneously you will have to give a methylene blue for treatment of methemoglobin, and you will require a hyperbaric oxygen. In carboxyhemoglobin, again 100% oxygen, or we call as hyperbaric oxygen. So hyperbaric oxygen will be very helpful in a carboxyhemoglobin, we already mentioned this too, and methemoglobin, very helpful. What are the complications of severe hypoxia? If it is very rapid and severe, dangerous one. As far as CNS is concerned, cerebral edema, raised intracranial pressure, herniation, and person will go into coma, seizures, and person can die. In not so rapid, moderate, lactic acid acidosis, high anion gap metabolic acidosis, and secondary complication because of acidosis. As far as the cardiovascular system is concerned, person can have anginal pain and person can even develop acute myocardial infarction, and congestive heart failure may be precipitated. Even you can have a precipitation of a cardiac arrhythmias. As far as respiratory system is concerned, person can develop type 1 or type 2 respiratory failure, and secondary to type 1 type 2 respiratory failure, person can go into cardiovascular failure, and that will be respiratory cardiovascular failure, and person can have even death. So these are all the common complications which can happen secondary due to what we call as a severity and rapidity of hypoxia, depending upon that. There are some complications of giving a hyperbaric oxygen. You must keep it in mind. This can be asked to you as a short note or in a oral. So do remember, because of excessive oxygen therapy or hyperbaric oxygen, you can have a retrolental, that is behind the lens, your eye. You can have a fibrosis called fibroplasia, and that is dangerous, and that can give rise to blindness also. And blindness can be due to vasoconstriction and ischemia. That is very common in a premature infants. Do keep it in mind. And also it can produce lenticular, that is lens fibrosis. Do keep it in mind, and that can also have effect on your acuity of vision. Also, depending upon how fast you are giving and how much concentration you are giving, you can have consolidation, that is in respiratory system. You can develop even fibrosis, and that can reduce the lung capacity for oxygenation. So it can produce a direct damage to the lung, that is consolidation can be there, and you can also have a fibrosis because of hyperbaric oxygen. So atelectasis can be there, and you can also have obstruction, mucus plugging, hypoventilation that can develop because of high flow of oxygen. So whenever you give, you will have to give with what we call as a humidified oxygen should be given, and because of good flow of oxygen, you remove the hypoxic drive, carbon dioxide is washed out, and when carbon dioxide is washed out, person can go into hypoventilation with acidosis, and also person can end up with what we call as a death, and that can happen. So you can have oxygen toxicity, cerebral oxygen toxicity, pulmonary oxygen toxicity, which can be chronic. So do remember, all these things can happen. So I end my lecture here. Good number of things can be asked to you in your oral, and good number of things can be very useful to you in your everyday practice also, because you will come across hypoxia quite common. You will be giving oxygen therapy to some of the people, and when you are giving an oxygen therapy, do keep it in mind how fast to be given. All depends upon the severity and rapidity of hypoxia and effect of hypoxia, hypercarbia, etc. on body, and depending upon that you decide the treatment. So this lecture will be very helpful, and this is the basic for dyspnea, cyanosis, and good number of chapter in respiratory system as well as cardiovascular system, like congestive heart failure, left ventricular failure, respiratory type 1, type 2 failure, etc. All those, the basic concept will be how you get hypoxia and what are the different types of hypoxia and which are related. So I feel this lecture will be very helpful to you. If you like this lecture, please press button like, and if you are not subscribed, you can subscribe my channel. If you feel this is helpful to your friends also, you can share with your friends. So once again, I thank you all for taking out time. I know that your time is valuable, and I appreciate you for spending some of the time with me. So see you in next lecture.